Welcome all of you to this live program at Authentic Principles. Today, our guest of honor is Dr. Freek Hollman from Venlo, Netherlands. Dr. Hollman is a fellowship-trained shoulder specialist and currently working at the Victoria Medical Center in Venlo, Netherlands. In 2021, he finished his orthopedic residency program in the southern part of Netherlands and defended his thesis on optimizing care on rotator cuff pathology. In 2022, he traveled to Brisbane, Australia to work with Dr. Kenneth Bush and Dr. Ashish Gupta to further specialize in shoulder arthroplasty and arthroscopy. In his current position, he works together with his colleague, OK Lambers Spink, and started as shoulder isopos approved fellowship along with this ISIC. His research department, the Venlo Shoulder Unit, focuses on different fields, which are, amongst others, the neurogenic thoracic outlet syndrome. So today, it's my great honor to introduce you to Dr. Freek Hollman from Venlo, Netherlands. Over to you, Freek.
Good afternoon, good evening, actually. Thank you very much for the kind introduction, and thank you very much for introducing me to tell something about neurogenic thoracic outlet syndrome. Something that I started in the beginning when I traveled from Brisbane back to the Netherlands. It's quite challenging to start building up this practice and treating these kind of patients. I think it's one of the most challenging condition in shoulder pathology in the shoulder world. So I'm very happy that I'm here together with Bart van der Pas. He's the physiotherapist where I work closely together with, and you see our neurologist Mitte de Vrijer. So without them, I wouldn't be able to do all this. And of course, my direct mate, Okke Lambers Heerspink, he's also a shoulder specialist. Yeah. So I think Dr. Gopalan already told you about what my path was. So I won't tell much more about that. I don't think many will know where Venlo is located. It's in the Netherlands, a bit more in the south of the Netherlands, close to Germany, and it's a very nice city. So, neurogenic thoracic outlet syndrome, how we started it. So, during my fellowship in Australia, I was able to learn from Dr. Kabush and Dr. Gupta on this condition. And also in the literature, you see promising results on endoscopic plexus release, where currently, at least in the Netherlands, the first rib resection is the golden standard, as well for neurogenic as for vascular thoracic outlet syndrome. So in 2023, we started with the neurogenic TAS team here, and it's a multidisciplinary approach. Together with a physiotherapist, neurologist, radiologist, who's not here right now, but we need them as well. Very important in our group, orthopedics and the rehabilitation doctors. So what is neurogenic thoracic outlet syndrome? Mainly, it can be divided into three anatomical locations of potential compression. So number 3, you see it there, that's at the level of the pec. Of the pec minor. The level 2 is the costoclavicular compression site, and this is in the scalenus triangle, where mainly the anterior scalenus is involved in the compression. So that's good to know. So looking at the statistics, 90 to 95% of all thoracic outlet patients have a neurogenic one. The rest of them is vascular. It's thought to be vascular. Then mostly affects younger females, and it's predominantly the retropectoralis minor compression site, so the third one in the first picture, and it can be post-traumatic, so it's macrotrauma, or it can be repetitive work-related stress injuries, and that's due to microtrauma, but mostly the cause is unknown. It's a very vague condition actually. So the pathoanatomy is thought that it starts with pectoralis minor hyperactivity, and then shortening and fibrosis of this muscle, which leads to scapula to be chronically protracted posture, and that decreases the volume of the retropectoralis minor space. when you elevate the arm in this position, you will get compression on the brachial plexus. And you can even get tethering on the suprascapular nerve. And that's also described in the paper from Thibault Lavas. So is neurogenic thoracic outlet syndrome the same as the pectoralis minor syndrome? I think these terminologies goes a bit hand in hand, not always, but I think in terminology might be a lot of comparison. So it's thought to be secondary to scapulothoracic abnormal motion, and you can have direct pectoralis minor compression on the brachial plexus and the vessels, and it's graded in different kind of severities. So the first grade, it's minor, and it starts with muscular pec minor syndrome, which is not continuously there, but when it aggravates, gets bigger, it can lead to neurogenic pec minor syndrome with continuous or temporary compression on the plexus, giving also temporarily complaints of compression on the lower plexus particularly, or multifocal thoracic outlet syndrome when it goes into the scalenus triangle as well. So that can be divided then into a single, double, or triple crush syndrome, where single is only at the level of the pec, double costoclavicular part as well, and the triple crush syndrome goes into the scalenus triangle as well. So single, double, triple, it's clinically very challenging to discriminate between these three conditions. It's based on a set of symptoms. And if you look at the pec minor syndrome, that may so lead to a double or triple crush syndrome. So the longer you wait and the more the problems you can get, you can speak about double or triple crush syndrome. So if you look at the symptoms of neurogenic thoracic outlet syndrome, it's just in general, it's mainly pain around the neck, shoulder, trapezius, medial scapula, arm, and or hand, and are often accompanied by muscle spasms. You can also have subjective paresthesias and or motor deficit in the arm or in the hand may be present, and it's mostly the lower plexus where it's involved. And what I most often see is that in the fifth and the fourth digit, there's pins and needles, and also at the medial side of the arm. So this part. And then worsening of symptoms with shoulder elevation or prolonged activity in a certain posture, certain position. There's no clear description, and again, it's a vague set of symptoms which might lead to your diagnosis. You can have a tenderness and positive Tinel sign of the pectoralis minor, and also on the scalenus triangle. You can have scapular dyskinesia, and clinically very known presentation is the Gilead-Sumner hand, which is a late presentation of a long ongoing neurogenic thoracic outlet syndrome. There are several tests you could do, and we just struggle and discuss with other people how they diagnosed their patients with neurogenic thoracic outlet syndrome. And the most commonly used was the EAST, the elevated arm stress test, which you see on the right, where the guy just elevates his arm in this position, and then he starts to open and close his fist. And he goes on to like 3 minutes and until he's not able to complete the exercise. And if it's a real neurogenic thoracic outlet syndrome, even after 10 seconds, it's already pretty difficult to close and open the fist. Then you've got the upper limb tension test, and you see different kind of postures where you can stretch the plexus, and you see these postures on the right. Then also you got the Tinel sign of the scalenus and of the pectoralis minor, which we previously discussed, which could be helpful in provocating the complaints. Well, diagnostics, they're not very useful, unfortunately. So you could rule out shoulder pathology on the MRI or compression of the brachial plexus at some level, which you can do also with an MRV or MRA in different postures where you look at the vascular supply through the artery in the vein. And you can do an EMG of the brachial plexus. You can do an ultrasound, but they are again mostly inconclusive. And if you make an ultrasound of the plexus, you could look for the wet sickle sign with compression on the truncus inferior. Then also, which we found very useful, are the muscular blocks. You can give a PEC minor block, just intramuscular, with 5 cc of an analgesic, ultrasound guided, or in the scalenus muscle, the anterior scalenus muscle. So if you look at the literature, there are not many studies if you go into treatment of the neurogenic thoracic outlet syndrome in terms of scopic releases. I think one of the first, at least known people that started this and popularized this, which we were very thankful for, is Thibault Lafosse, together with his father. And they showed in their prospective case series that the pain and paresthesias were relieved in 80 to 90% of the cases, which is pretty successful. So it's a good option. But the patient selection is key, and that's challenging. So how did we build up our current practice? So what we think is important, again, is patient selection, diagnostics, surgical treatment, non-surgical treatment, and also put some research behind it, just to see what we're doing, if that's also correct and we're helping our patients. So this is a workflow we worked on the last couple of months, and when the patients come in, he's seen by the neurologist or the orthopedic surgeon. And when there's a clinical suspected neurogenic thoracic outlet syndrome, we refer them to each other. And then there's a workflow where we rule out shoulder pathology or any nerve compression in the level of the neck. We perform an NPM block. We start physiotherapy. We do an ultrasound of the plexus, and we make a thoracic aperture and an EMG. And then we do that for all our patients. And for the EMG, we look for the wet sickle sign. And for the NPM block, if it's effective, yes, we continue physiotherapy. And we think it's at the level of the pectoralis minor space located. And if that doesn't respond in 6 months to physiotherapy, we proceed to an all-endoscopic plexus release. And we need to consent, all the 3 of us, to be able to treat somebody surgically. So it's a pretty long and intense process. So if it's not effective, the NPM block, that might be the level of compression might be a bit higher. So for example, in the scalenus triangle, with compression caused by the anterior scalenus, we can give a scalenus block, and if that's effective, well, we don't release the scalenus anterior scopically, so then we would refer them to another center to consider that for a first rib resection at this point. Who do we operate, or who do we go for when we go for physiotherapy? Well, it's not very clearly described, but mostly it's the complaints are because of micro or macro trauma. They have pins and needles or hyperesthesia of the lower plexus. It's posture dependent, and mostly they complain of a dead arm feeling. And we perform the EAST and the ULTT, and that should be positive. Then there's a high suspicion of a neurogenic thoracic outlet syndrome. Then we rule out any accessory rib or prolonged transverse process. Then in our practice, MRI of the plexus has limited value. We started doing this, but they were all negative. So we actually, stopped doing that. And we more rely on a ultrasound and the EMG studies. You could do it in different postures to look for vascular compression in a dynamic MRA or MRV. So here you see a patient where we perform our NPM block. We don't really put the injection in, but just to show you the technique. So here you see the pec minor and the coracoid process, and you just put your needle in that muscle and inject 5 cc of analgesic. Then you can make an ultrasound and look for a wedge sickle sign. That's the only thing you could actually see in our point of view, to look if you're looking for neurogenic thoracic outlet syndrome. And in your EMG studies, you can rule out other possible diagnoses, such as ulnaropathy and carpal tunnel syndrome, which is just more peripheral located compression sites, and something to support your lower brachial plexopathy. But the results are variable, and some people, they don't even have EMG abnormalities, but still they benefit from surgery. The abnormal results may mainly be in cases of advanced atrophy of the hand, in the iliac ulnar hand. So you can also perform an anterior scalenus block. So at this point, we haven't performed these blocks yet, but we set up everything to start this together with the radiologist. And we would like to do an east before and after the muscle block and the ULTT before and after, and see if that's effective. So it's challenging again to decide where the level of the compression is. If the MPM block is ineffective, should we perform a scalenus block? And what to do if it's effective? Should you do first rib resection, or should do also a scalenus muscle resection? And can you do that scopically? There's some things that we are still finding out. But the MPM blocks, if they're effective, they're the most easiest to treat, and you can consider them as well as pec minor syndrome. So the surgical treatment, actually the non-surgical treatment, the non-surgical treatment, there are general goals. So Bart just worked very intensively on this phased strategy, where it's focused on decompression by stretch on the scalenal, costoclavicular, and pectoral port, mobilizing the adjacent joints, and reducing the mechanosensitivity, optimizing motor control of the scapulothoracic motion, optimizing postures, and also looking how these complaints are related to daily activities and work-related activities. So some of these stretch tests are shown here. This is an example of an anterior scalenus and pec stretch. And here you see a anterior scalenus stretch test. You can do it in different postures, but it's meant to just stretch the anterior scalenus muscle. You can also stretch the pectoralis. This is a good posture to do that, and you can really feel that tension coming, and you can also do that in different, perform that in different positions, and also the serratus motor control for the scapulothoracic range of motion. So coming to the surgical treatment, I've just created a small short video for you. Here you see from a posterior view, recreate the D portal, and then looking from anteriorly from the shoulders, you can see at the picture here on the right. This is the coracoid process, and there's an anterior portal as well coming, and the medial portal where we perform our pec minor release. That's the pec minor that's taking off from the coracoid process. And you should be very careful with the musculocutaneous nerve, which is directly behind it. And before you start with this, you also identify the axillary nerve, by the way, from the D portal. So we complete our release of the pec minor, which is really important as with the arthrolalgia as well, to go all the way down. And then there's the nerve, musculocutaneous nerve. And you can just bluntly dissect this further, and just be very careful. Then we look, as you can see the position of the camera, we go more medial. On the top, there's the clavicle. So we look for the subclavius muscle. That's there. There you see the muscle fibers of it. And behind the structure, there's the vein and the artery as well. So you should be very careful in dissecting this muscle. But this is actually the site of the compression of the costoclavicular space as well. So it's more than only a pec minor release. So we call it infraclavicular endoscopic plexus release. And when you release this muscle, you really have the feeling that it opens up. And in a few seconds, you will see the posterolateral cord as well. And in some post-traumatic cases, you might find some fibrotic strands as well, which could be carefully taken down. And now the subclavius muscle is almost fully released. Right. Then we do a final check. And we slowly retrieve our camera, going backward. Almost. And you see that the retropectoralis minor space is completely released. All right, so what are the results? So at this point, we treated 2 patients where we got the results from. So you can look at the TOS disability scale, which 10 is the highest score, and both the first and the second patients had a score of 8 and 9, and post-operatively they scored 2 and 0. That was after 6 weeks. And they even after, directly after surgery, they already felt that that nerve, that compression, that radiating pain, was already a little bit gone, and after 6 weeks they had these results. And looking at the CBSQ, which is the cervical brachial symptom questionnaire, you see that they also dropped down from 67 to 6 and from 72 to 0. And the quick dash, and the high score is more pain. You go from 70 to 16 and 55 to 0. So that's a promising result, but still it's very challenging to select the correct candidates for this procedure. So in conclusion, neurogenic thoracic outlet syndrome exists. The diagnosis is challenging, and surgery, in our opinion, should be a last resort option. And endoscopic brachial plexus release, it works. It's got good short-term results, but the multidisciplinary approach is key. You really need a team to start with this. So in discussion, things that we are still struggling with, what is the value of the EMG? What's the value of the MRI? MRI of the shoulder, MRI of the plexus. Should we do an ultrasound? And what's the value of that? Should we rule out the more rarely cause of neurogenic of thoracic outlet syndrome, which is the vascular cause? Should we also include the suprascapular nerve release due to tethering? We didn't do that. But in the paper described by Thibault Lafast and their colleagues, they included the supraclavicular neurogenic suprascapular nerve release as well. When should you perform surgery? So how long would you continue with physiotherapy and decide to go for surgery? That's something we're searching our way as well. If you have a more side of compression more towards the scalenus, should you include an anterior scalenus release, or should you do the first rib resection? Which in my hands I won't do at this point an anterior scalenus release, and just a techniques that was shown before. So the clinical diagnosis is a take-home message. We have to agree. If we don't agree, we don't move forward. The surgical treatment is a last resort option. We do an infraclavicular endoscopic release, which seems to be a viable option, and it's a team effort together. So thank you very much for your attention.
Thank you, Freek, for this wonderful presentation. Freek, you can stop sharing. Thank you, Freek, for this wonderful presentation, and congratulations to all three of you for this wonderful work that you're doing at Venlo, and also congratulations for getting accepted from the ISACOS and CICIG as training centers.
Thank you very much. Thanks for the invitation.
Thank you, Freek. Freek, let's have a short Q&A. Question answers, yeah. Freek, there have been many tests described, right? The Wright's test, the Roos test, the elevated arm stress test, the exaggerated maneuver, the military brace maneuver, so many tests, right? Adson's test. So what do you think is clinically useful when you come to the diagnosis of neurogenic thoracic outlet?
Well, that's a good question. I think you have to just pick one and just go with this one test or two tests or set of tests. But you can do a lot of tests, but you need to find a way, like a structure for yourself and together with the team to talk the same language and to do the same test. So we mainly perform the EASE test. And
They're like elevated arms.
Yeah. And that's what we do. So we do it before giving a muscle block, and then we do the test again and see if the test goes easier. And we do the ULTT, the upper limb tension test. And I think we do that sort of, I think, a bit differently. What I do is just I put them like this, put the hand like that, and then I try to aggravate it by giving dorsiflexion in the wrist as well. I think, Mirti, you do it a bit the same, or do you?
Yeah, yes, a bit the same. I think the EASE test we perform the same. There's not much chance of a difference in performing that, I think. And the ULTT test, yeah, I perform it like this.
Yeah.
Yeah.
Like in the picture that we've shown, it's different ways of doing it. You have to stretch you have to stretch the plexus. That's what you need to do. And if you do it with all these kind of tests, you can do them all. You can do them all, but you need to have a sort of workflow. So we find these tests the most important ones to.
Yes, and it's also based on the work that they did in the TOS center in Eindhoven, which is a big center for TOS patients, where they also perform the decompressions and first rib resections, and they also find these tests, so the EASE, ULTT, and the Tinel of the pectoralis and the scalenus, the most useful tests. And they have seen, well, I think hundreds of TOS patients, so that's also why I chose to do these tests, because it's based on their experience with thoracic outlet syndrome.
Yeah.
And Freek, when do you actually suspect based on symptoms? For example, someone who you have treated for rotator cuff disease not responding to conservative measures, and when you have some kind of atrophy on the ulnar side of the hand, or when do you actually suspect, okay, this could be neurogenic thoracic outlet from the symptoms, pain alone?
It's a good question, because a lot of patients, even with rotator cuff disease, have this sometimes sort of pins and needles in that particular place. So you should treat, if there's a rotator cuff problem, you should treat the rotator cuff problem, and just ignore, that's what I think, ignore the neurogenic thoracic outlet symptoms a bit, and go for physiotherapy as well. I think that's very important to have a good program to mobilize the adjacent joints and to mobilize that minor retropectoralis minor space as well. Well, and if you've treated your cuff problem, you started your physiotherapy program, and for example, you have a positive muscle block, which totally resolves the symptoms. reduces the symptoms, then yeah, you might consider it. But I think that's not the most ideal patient because it's not very predictable, I think. But I have no experience with rotator cuff diseases and neurogenic thoracic outlet syndrome. No.
And Freek, one of the most difficult parts in this particular subject is making a diagnosis, right? So we mentioned about the clinical tests, ultrasound, the vesicle sign, MRI. And what about the role of neurophysiological testing, the NCV and EMG, looking at sensory nerve action potentials?
Yeah.
The SNAP.
Yeah, so well, I think it's the best question for a neurologist.
Yeah.
So you might answer that if you have a good answer.
Yeah,
or
well, it's the snap of the cutaneous antebrachy, the median cutaneous antebrachy nerves, and the ulnaris, the sensory nerve action potential of the ulnaris nerve. Those are useful, but if you look at the literature, then the EMGs that are abnormal is mainly in patients with atrophy and objective sensory deficits, and most of the time that's in Gilead-Sumner hands, with people who also have a clear clinical picture, and most of the time also with first rib accessory first ribs or other bony anomalies. So the literature with abnormal EMGs is in clinically quite defined cases, and the subgroup of people with a bit more vague symptoms, where you cannot really find any deficits when you examine them, but they complain of radiating pain and paresthesias. Those are people with normal EMGs, but the people we that were treated with an operation here with endoscopic release both had normal EMGs, but with a good result after release.
So it might be perhaps a bit too late if you are.
Can be, but in the literature that you find mainly that the patients with already atrophy or Gilead-Sumner hands have abnormal EMGs, but those are also the people who really have that supraclavicular problem.
Yeah.
And the more difficult group of patients, I think, is where you suspect maybe a thoracic outlet syndrome, but they have a normal aperture. You have no anomalies in the supraclavicular region, and then it can get difficult to distinguish who is a real thoracic outlet syndrome patient and who has something else.
Thank you. Freek, just one last question before I end the session. Now, Freek, you worked with Kenneth Cuthbush and Ashish Gupta, right? So what has been your experience over there with your with the same procedure, the endoscopic brachial plexus release? Any particular tips and tricks that you would like to share? Because this is really complicated, right? You go right below the clavicle, and there's a lot of neurovascular structures around there. The potential for injury is very high, isn't it?
So it's mainly that with that I learned this technique from Ashish Gupta. We worked together with him with a couple of cases, and it's you really what I think what's important that you have to just work step by step, very slowly, and just have a clear view every time in what you're doing, and you should be familiar with scoping at the front of the shoulder. And there are a lot of, so how I started this is I used a lot of steps from other procedures to incorporate that in this praxis release. So for example, pec minor release is also a step of arthroscopic Latarjet, as well as identifying the musculocutaneous nerve, identifying the axillary nerve. So actually then you only need to release the subclavius muscle and you're there. But I think that part is pretty, as you saw in the video as well, I was just doing that very slowly, muscle fiber by muscle fiber. to make sure you don't hit the vein or the artery or the plexus. So it's and I don't give them a plexus block. So I just leave I don't want to give them an interscalenus block. So I just want to have every response from the plexus, not paralyzed as well. I just want to have a really good feedback of that, and just take your time. Yeah.
Thank you, Freek. Freek, I think that's all the questions that we have for the session. Thank you for the wonderful presentation, all three of you, and congratulations for all whatever you're doing in Venlo. Thank you so much for joining in.
Thank you very much.
Thank you.
Have a great weekend.
Bye.